So I would like to present our first speaker, Dr. Ahmed Ibada Salim. He's going to present an introduction to PET-CT. He currently serves as a lecturer of radiology at the University of Alexandria School of Medicine, Egypt, as well as a clinical assistant professor at the University of Utah, Salt Lake City, USA.
Thank you so much for having me today. Thank you for having me today. Today we'll present an introduction, understanding the basics of PET-CT. So the goals and objectives of this talk will be to introduce the most common clinical indications of PET-CT, talk about the physical properties and intracellular kinetics of PET tracers, patient preparation, normal and altered normal biodistribution, patient protocols and doses, as well as the artifacts and other FDA-approved non-FDG tracers. Okay. This is the agenda for the talk today. Okay, so PET-CT, as you all know, has expanded in the clinical practice and specifically in the field of oncology. It offers a comprehensive review, merging both functional and anatomic information about the tumor. The most commonly used PET tracer nowadays is FDG, which is a glucose analog. Common indications, FDA-approved indications for PET tracer include oncology, for tumor evaluation, detection of unknown primary, staging of tumors, and recurrent disease. Other non-oncology indications include lung nodule evaluation, dementias, cardiac variability, and cardiomyopathy in sarcoidosis, as well as in infection and inflammatory disorders. So fluorine 18 is a PET tracer that is labeled to the FDG, fluorodeoxyglucose, which is a glucose analog. After injection into the patient, it undergoes decay into oxygen, and then it decays by positron decay and produces a positron which interacts within the tissue, producing two photons, and then it's detected by the camera. Within the cell, glucose, as we said, is a glucose analog, so it does undergo uptake by the GLUT receptor, GLUT type 1 receptor, and then it gets phosphorylated in the tissues and then gets trapped in the cell, unlike glucose, which undergoes metabolism into the Krebs cycle. So basically, the uptake depends on the hexokinase concentration as well as the glucose 6-phosphatase, which is the antagonist for the hexokinase. So in tumor cells, they do have most of cancer cells will have an upregulated hexokinase, and most cancer cells will show uptake on FDG. So this is the normal biodistribution of FDG. As you see, there's prominent uptake within the brain, moderate uptake within the liver, and the tracer is actively secreted into the kidneys and urinary bladder. Patient preparation is very important to maximize the sensitivity of the scan. So a patient needs to be fasting and have an adequate blood glucose. Usually, we allow up to 250 milligram per deciliter. We also need to time the insulin and oral hypoglycemic agents, And the reason is this PET tracer is similar to glucose. So if we have a high blood glucose or insulin medication, it will compete with the glucose and lead to altered biodistribution. Patients need to be well hydrated, and they need to avoid, they need to empty their bladder because of the tracer excretion in the bladder. They need to avoid any strenuous exercise, talking, chewing gum, and they need to be warm in a quiet environment. So those are different cases where there's altered biodistribution of the FDG. The first one here, image here, you see this is a diabetic patient. There's increased endogenous insulin stimulation leading to FDG trapping in the muscle and the heart. The other images are also seen due to altered biodistribution, but due to different causes. This is another patient who has COPD with increased respiratory muscle effort, leading to activation of the diaphragmatic muscles as well as the intercostal muscles. The other last two patients were patients who went to the gym before the exam, so they had stimulation of their biceps muscle as well as the quadriceps muscles. This is another case where a patient had an altered biodistribution due to brown fat activation, and that's why patients need to be in a warm environment. If the brown fat is not under control, they may need to be medicated. This is another form of brown fat, which is called the lipomas hypertrophy due to stimulation of fat within the interatrial septum. And those all can be a source of pitfall when interpreting the PET-CT. This is another patient who was actively breastfeeding before the scan, so you can get increased uptake within the breast tissue. Factors that may alter the PET scheduling in setting of a chemotherapy. We usually require that the patient has an adequate spacing of the treatment, so we require waiting at least 3 weeks before their chemotherapy, 4 weeks after surgery, and 3 months after radiation. We also recommend waiting for a week after getting their granulite stimulating factor because it can lead to myostimulation and can hide any underlying lesions. Breastfeeding, we recommend patients to discard any breast milk after 12 hours, and the reason is the fluorine 18, even though it's not actively excreted in the milk, we want to avoid any close contact between the baby and the mom. So we usually recommend not having any breastfeeding and close contact for 12 hours. Depending on the insulin used, if it's a short-acting insulin, we usually space the insulin like 2 to 4 hours. If it's a short-acting before the scan, if it's a long-acting insulin, we usually require 8 to 12 hours. Metformin can be a source of pitfall because metformin leads to increased GLUT receptor type 2 uptake of the FDG, so it could lead to increased bowel uptake, as in this case. We do have a lot of bowel uptake within a diabetic patient. So FDG dose administration, we usually give 7 to 25 millicuries, roughly 0.14 millicuries per kilogram. It's injected intravenously. We usually image the patient 45 to 60 minutes after the injection. Some studies have suggested waiting for up to 120 minutes to enhance the tumor to background ratio, and this comes to the fact that tumor cells will have more hexokinase, so they can trap more FDG within the cells. It is preferable to administer the tracer within a peripheral line and avoid any port or any indwelling caster because tracer can sit within the caster or the port and it can cause artifacts. When evaluating an axillary nodes or breast cancer, the tracer should be injected on the contralateral side because if you don't do so, IV contrast or FDG can hide underlying axillary nodes or supraclavicular lymph nodes. Radiation exposure, 2/3 of the radiation dose from the PET-CT is derived from the CT component. Depending on the protocol used, we can use a high-dose CT, moderate-dose CT, or low-dose CT. It depends on what protocol we use. Usually in pediatric patients, we use a low-dose CT. And with the development of the new time of flight and digital PETs, the dose has significantly decreased. In general, we use an eyes to SI scan, but again, depending on the type of cancer we're imaging, we can adjust this protocol. So usually in cases where there's malignancies that are known to metastasize to the distal bones or skin, we get a whole body, so from top of head to the feet. In patients who are known to have a head and neck cancer or brain malignancies, we usually get a dedicated CT in addition to a PET CT of this region. Use of oral and IV contrast is a big, it's very, very, there's a lot of different protocols for that. So some institutions actually do not use oral and IV contrast, but again, it depends on the type of cancer we're imaging. So to be able to subjectively measure the uptake related to the tumor, we use standardized uptake values, which takes in consideration the radioactivity concentration injected into the patient as well as the decay. Fluorine-18 has a 2 hours decay, so technologists need to let us know exactly when the tracer was formed and when it was injected to count for that. We also need to know exactly the weight of the patient. SUVs, different SUVs can be used, so we can use SUV max, we can use SUV mean, or SUV peak. SUV max is usually used, and it focuses on the higher count within the pixel. Factors that can affect the SUVs are biological factors and technologic factors. I think that's very important for us to know because this will affect the accuracy of the measurements we're measuring on the patient. So biologic factors include the dose of the patient we injected, blood glucose levels. As we said, we usually allow up to 250 milligrams. Above that, we will require the patient to be scheduled because this can affect the sensitivity of the scan. Fat and muscle proportion. Fat does have low uptake of glucose compared to the muscle, so this again will affect our interpretation of the scan. Body weight, as well as respiratory motion and lesion localization. Technologic factors, uptake time. So if we image after 90 minutes compared to 120 minutes, the use of oral and IV contrast. Even though the oral and IV contrast has increased the sensitivity of the scan, it has a very minimal and trivial value affecting the SUVs, roughly 6%. And again, the dose of the CT and the field of view acquired. Couple of recommendations to unify the SUV measurements. So whenever possible, try to obtain a baseline and a follow-up scan on the same scanner. Measure any residual activity in the syringe and injection tubing before and after injection to accurately know exactly how much did you give to the patient. A minimum uptake of 60 minutes is required. Maintain the same technique and reconstruction parameters used in the scan, so 2D versus 3D, field of view, a dedicated CT of the head and neck or brain. Weight the patient every time before the scan, and consider using the same CT protocol, whether you used oral or IV contrast. So the way the PET CT imaging work, we obtain a PET image and then a CT image, and then we fuse both images together. So fusion of both images will lead to artifact because they are not acquired simultaneously at the same time. So this can lead to misregistration due to either patient motion, due to respiration, and this can be a problem, especially in the lung bases and around the upper abdomen in the diaphragm. So it's really important to review both the CT and the PET portion, and specifically the uncorrected versus the corrected image. So this is a patient who was due for his follow-up scan for myeloma. And as you can see, he does have multi-level compression deformities and kyphoplasty. And we can see at one of these levels, there is increased uptake related to the kyphoplasty. So we really don't know if this uptake is due to any underlying myeloma. So you need to check for the corrected versus the uncorrected image. If the uptake is due to high density material, it will usually significantly drop on the uncorrected images. And as you can see down here. This is another patient who had surgical resection of one of solitary liver metastases, and he was also due for his follow-up. We can see that there's increased uptake on the corrected image, and then on the uncorrected image, the uptake significantly drops. And this is due to attenuation artifact. So other commonly FDA-approved non-FDG tracers will include the PSMA, including fluorine-18 or gallium-68, prostatic-specific membrane antigen, fluciclovine, which has now been replaced by the PSMA. We use gallium-68 or copper-64 dotatate for imaging of neuroendocrine tumors. We can also use sodium fluoride for bone tumors. However, nowadays we usually use bone scan rather than the fluorine 18 PET-CT. So this is a MIP image for gallium 68 and copper 64.8. So we usually use this tracer in well-differentiated gastroenteropancreatic neuroendocrine tumors. It can also be used for bronchial carcinoids and medullary thyroid cancer. The mechanism of action, it does bind to the somatostatin receptors, specifically type 2 and 5, which are highly expressed in the GEP NET tumors. The dose is significantly less, as you can see, compared to the FDG, so we give 4 millicuries. And the uptake, the normal distribution, the uptake is most intense within the pituitary gland and the spleen and the onset process and the kidneys. Patient preparation is different than FDG, since this is not a glucose analog, so you need to hold any short-acting somatostatin analog for 1 hour before the scan, and they need to have at least 3 to 4 weeks since they had their long-acting somatostatin analogs for neuroendocrine therapy. Fluciclovine Axamin, it was used for prostate cancer. As I said, it now has been replaced by PSMA. The mechanism of action, it's an amino acid analog, so it's highly expressed within the muscles, liver, and pancreas, as you can see. The dose is roughly similar to the FDG, so it's 10 millicuries. Uptake is most intense in the liver, pancreas, and muscle, as expected, because those are the sites for amino acid senses. Usually we image very early, like 4 minutes compared to 60 minutes, and the reason is you don't want to wait until all of the tracer is taken by the normal muscle. Fluoroestradiol, it's also an FDA-approved tracer used to image estrogen receptor positive breast cancer as well as ovarian cancer malignancies. The dose is 5 millicuries. You do have a lot of uptake within the venous site of the injection as well as within the liver and the bowel. One of the keys for patient preparation is patient needs to have a fatty meal. It's an optional and it differs from one institution to another, but the idea is to clear the liver from the robust uptake. Gallium-68 and fluorine-18 PSMA. This has been approved for for prostate cancer, high risk prostate cancer, baseline staging, as well as to identify the source of the biochemical recurrence. And patients who are eligible for Pluvicto, which has also been recently approved in the US for treatment of prostate cancer, they usually require this before the scan to assess if the patient will be responding to the Pluvicto. Mechanism of action, it does bind to the PSMA antigen expressed in the cancer cells. The dose is 9 millicuries. We usually image from the top of head to the mid-side. Patient preparation, the patient needs to be well hydrated, void before the exam, and we need also to check for any medications that may interfere with that, including the anti-androgen deprivation therapy. The last PET tracer that I'm going to talk about is the sodium fluoride, which there's no criteria to know exactly when to use that, but it's usually, it can be used to image infection, inflammation, AVN, trauma, metastatic disease. The only downside for this PET tracer that is associated with a very high dose, so the energy for the photon is like 511 compared to the energy of the MDP for bone scans are like 140. So as you can expect, it has a lot of radiation exposure to the patient compared to bone scans. So nowadays it has been almost replaced by bone scan. And we can use that if there's a problem-solving question. Mechanism of action, it does attach to the bone, normal biodistribution. It does attach to the bony tissue and is actively excreted into the kidneys and urinary bladder. Okay, thank you so much.
In Huntsman Cancer Institute, Center for Quantitative Cancer Imaging and Department of Radiology, University of Ottawa, subspecialist in breast and nuclear radiology, principal investigator on 9 clinical trials, sub-investigator on 17 clinical trials. Primary focus is 18 fluorescent in 18 fluoro estradiol research, founder and host of the Radiology Review broadcast, more than 120 episodes to date, and international audience.
All right, thank you so much. Let me share my screen here. And can I confirm you can see that? Is that good? I'll assume so, otherwise let me know. So thank you so much for inviting me to speak. I'm sorry I can't be there in person. That introduction to PET-CT was really fantastic. And I'm happy to talk with you about PET imaging for breast cancer, one of my passions in medicine for sure. I have a few disclosures. One, I am on the GE Healthcare Advisory Board for fluoroestradiol, and I will be talking about that today. But we'll be sticking to the FDA label and indications specified there. So when we talk about breast cancer technologies, there's kind of a bifurcation. There's two ways of dividing how we image breast cancer. And one is breast cancer specific, or I should say breast specific imaging. And what I'm talking about there is mammography, breast ultrasound, breast MRI, where we're really tailoring our imaging to the breast exclusively. And then we have the bottom three here that are bolded, where we are looking beyond the breast to see what else might be happening. And this is primarily for systemic staging of breast cancer. We also can be evaluating adjuvant therapy response. So if a patient is on therapy, also, neoadjuvant and adjuvant therapy response, but typically with PET, we're doing adjuvant. They've had definitive therapy. And now we're looking to see, is all the disease gone? Is there persistent disease? Is there progression? We can also look for recurrence for patients who have a complete response to therapy initially. And there are options to do this beyond nuclear medicine, meaning primarily CT scans, and sometimes MRI has a role. But with nuclear medicine, we're typically talking about FDG PET-CT, but there's also an option for bone scans. On this lecture, I'll really be focusing on PET imaging. And FDG, as we've just learned, this is really assessment of metabolism. And we are looking for hypermetabolic sites of breast cancer throughout the body. And guidelines can vary on whether someone should have an FDG PET scan for breast cancer. Many places follow NCCN guidelines, and they specify currently that FDG PET-CT is typically considered an option for breast cancer staging at stage 3 or higher, and it is an option to CT chest, abdomen, and pelvis with bone scan. And it can also be helpful beyond staging for surveillance and evaluation for recurrence. And then our newer agent that was first approved for clinical use in France and is now approved in the United States, though not yet widely used, meaning that probably roughly 15 to 20 major centers are doing fluoroestradiol PET imaging, but that's it. A lot of centers aren't yet, but it's good to be aware of this because I do believe in the next 5 years, certainly, use of fluoroestradiol PET imaging for breast cancer is going to increase. And this is really imaging estrogen receptors. It's basically radioactive fluorine-18 attached to estradiol, and that then goes and binds to estrogen receptors and allows us to assess for areas of abnormal estrogen receptor uptake. I'll show you several images here, but it can be useful for certain types of ER-positive cancers. It is currently FDA approved, like I said, and the approval is specifically as an adjunct, or I think of it as a companion to biopsy to assess for ER status, and it also can be very helpful to troubleshoot cases where maybe FDG is indeterminate or you see some nonspecific bone lesions or perhaps something in the brain or lung, for example. And it might not be an easy site or even a safe site to biopsy. If you see uptake on something like an FES PET scan, that would strongly support the estrogen receptor positive breast cancer is there. And my personal greatest interest is, can we use FES to improve detection of cancers that tend to have some difficulty with FDG? And specifically there, I'm speaking about invasive lobular carcinoma, which is the second most common subtype of breast cancer, or low-grade, very early, well-behaved invasive ductal carcinomas. Sometimes those don't take up glucose with a lot of uptake. They are not super glycolytically active, and if they are ER positive, fluoroestradiol PET can help us there. Let's look side by side at an FDG PET CT scan and an FES PET CT scan, and you'll right off notice some notable differences. First, we'll go top down. You can see that the brain is very hot on an FDG scan, and it's not showing much uptake at all on an FES scan. That's a great thing because that allows us to be more sensitive for subtle areas of brain uptake when we're not competing with a high level of background uptake. As was already mentioned, you see this type of venous uptake on the injection side of the arm on nearly every FES injection. It is retention of tracer in the veins. You can try to flush with extra saline as much as you want, and that radiotracer will still stay in the veins. So it's just normal to be there. And because it is there, and you can see it extends into the axilla, I've seen cases where it also goes into the supraclavicular veins. You want to try to inject on the side opposite to where the breast cancer is, because this could potentially confuse evaluation for something like a subtle axillary lymph node. As we go down, notice this very intense hepatobiliary uptake with FES. That is a primary limitation of this scan, in that you may not see liver metastases very well or at all, and you really need to window these images as widely as you can when you're evaluating an organ like the liver to try to see any uptake of metastases that might be hiding underneath this really strong physiologic background uptake. Now, both FDG and FES have renal and urinary excretions, so you expect to see uptake in the kidneys, urinary collecting systems, and bladder. And then this is a slightly off-center MIP image here. And I want to point out that this right here is uterine uptake. And in a premenopausal woman, you typically will see some degree of uterine uptake. That is actually helpful when you do see it as kind of a positive control to know that estrogen receptors are in fact binding to the estradiol that you've injected. If you saw that endometrial or prominent uterine uptake in a postmenopausal woman, that might be an indication for something like a pelvic ultrasound. But in people who are premenopausal, most readers of FES that I've discussed with generally consider that to be physiologic as long as the uterus and endometrium appear anatomically normal. So let's talk about a few pearls for interpreting breast cancer on PET imaging. First, we want to really optimize our thoracic lymph node search, because when breast cancer spreads beyond the breast, it nearly always goes to the lymph nodes in the axilla first, and then Rotter's nodes, internal mammary nodes, and then once it goes beyond those, you're usually looking at potential distant metastatic disease. You do want to be aware that a lot of breast cancer patients, for various reasons, have risk for coexisting ovarian and endometrial malignancies. For example, tamoxifen, for patients who are on tamoxifen for breast cancer therapy or prevention, raises risk of endometrial cancer. And mutations like the BRCA1 and 2 mutations both can increase ovarian cancer. So you'll want to evaluate those as well. one pearl with HER2-positive breast cancers is that these are really the ones that have the highest rate of brain metastases. So you want to evaluate the brain very carefully with HER2-positive breast cancers. They will often also have an MRI ordered by oncology. And invasive lobular carcinomas, as I mentioned, can have weak uptake on an FDG scan, so you often have to increase your sensitivity when you know you're reading a scan that is invasive lobular carcinoma to realize that all you might get for positive lymph nodes, for example, is mild uptake. But if it's mild and focal and it's lobular cancer, that is suspicious. And for all breast cancers, common sites of metastases include lymph nodes. Like I said, that's usually the first area of spread. And then bone, liver, lung, brains. And I've seen a lot of skin metastases in breast cancer as well. These metastases tend to be in the breast or the anterior chest wall of the skin, but they can be elsewhere. So if you're seeing focal patchy skin uptake, view that with some suspicion and ask your referring oncologist or surgeon to evaluate the skin directly. Let's go through some lymph node levels. There are 3 axillary stations. I see these reported differently. Some readers of PET scans call these level 1 axillary nodes the axilla, and then anything that is behind the pec they call subpectoral. I think that's reasonably okay, but it's more anatomically accurate if you consider all of these axillary lymph nodes. Internal mammary nodes are not part of the axilla, but are definitely associated with breast cancer, and in some ways are fairly unique to breast cancer metastases. And then we have the Rotter space here, which is in between the pec major and minor. I have a star there. Where this space is, it's this fat in between. And if you have a node there, it's called a Rotter's node or an interpectoral node. And those are important to mention because Rotter's nodes are something that surgeons cannot easily access in an axillary lymph node dissection. And so it's important to point those out because they typically would not be removed and they might be considered for radiation therapy, for example. Moving on, so we have the level 2 nodes here. With the level 2 nodes, you want to see these behind the pec minor, which if I can show here, the pec minor is this muscle behind the pec major, and level 2 nodes should be in this space behind. And then going forward, these are kind of borderline level 3, but let's go with it for now. Level 3 nodes are going to be medial to the pec minor. So pec minor is here. Medial, that's a level 3 axillary lymph node. Let's now go through some specific cases. This first case is one that I really like, and many of the other presenters from Utah have seen this case as well. I think some of them actually read this scan and did a great job at it. This is a 74-year-old woman, and she had a presumed perineoplastic syndrome. And breast cancer is one of the first things that a neurologist will think of for many perineoplastic syndromes that they may encounter. This patient clinically presented with stiff person syndrome. That is something that is very commonly related to coexisting cancer, and breast cancer is high on the list. And so they ordered an FDG PET-CT scan to try to find if there is a primary tumor. In this case, the FDG scan did show uptake. In the right breast, there's focal uptake in this lateral right breast. There is also focal uptake in this right axillary level 1 lymph node. So this is highly suspicious for a primary breast cancer with local nodal metastatic disease. And then the thing I liked the very most about this case, beyond finding the tumor for the team, which is definitely helpful for them, is that we saw this patchy muscular uptake which corresponded clinically with the stiff person syndrome, which often has tightening and sometimes spasms of the muscles. Moving on to another case, this patient underwent a scan, and I've zoomed in on the thorax here, but underwent a FDG PET-CT scan for cervical cancer. This is a 50-year-old woman. And the point of this case is to show, first of all, that even on a cervical cancer scan or any FDG scan, you need to evaluate the breast, and there is in fact focal uptake. But not all focal uptake in the breast is actually going to be breast cancer. All right, in this case, this was recommended for dedicated breast imaging, reported correctly as potentially suspicious for a primary breast cancer. But on targeted ultrasound, which we have here, this is actually a dermal lesion, and you can tell that because it's in the skin above the dermal and subcutaneous junction here. And this was kind of a vague hypoechoic dermal inflammatory lesion, something like a sebaceous cyst, not a breast cancer. So not all focal uptake on a PET scan will end up being breast cancer. Nonetheless, you need to raise concern. You can give a differential, and then you need to recommend dedicated breast imaging, and your breast imagers will be able to sort out what's cancer, what's inflammatory, infectious, and so on. This is another case also showing FDG uptake in something that is not a breast cancer. This is something we encounter a lot in the post-surgical breast. Sometimes you cannot wait months and months and months to image, and even if you do, you still see uptake at the surgical sites. But I want to draw your attention in this case. This woman had prior breast mastopexy and breast implant removal. The PET scan was performed for pancreatic cancer staging. Uptake was seen in the breast and reported as possibly suspicious. Mammography was recommended. And I want to draw your attention that in the, sorry, it keeps automatically advancing, so just bear with me, but thank you. There is fat density in the center here. And on this lesion as well, you have peripheral uptake, but you have central fat lucency. And this corresponds very well on the mammogram. For example, here in the left breast, you see this very circumscribed, well-defined fat density mass. And what these are oil cysts. Another term that's interchangeable for this is fat necrosis. And areas of oil cysts and fat necrosis are very, very common at surgical sites in the breast. And they're also very commonly inflammatory. And typically you will expect some degree of FDG uptake, but not a cancer. This is a very unfortunate case that we all need to be aware of if we're reading PET on breast cancer cases. This is a 54-year-old woman, and on the left here is a normal screening mammogram. And what you see here on the right is a diagnostic mammogram performed only 3 months later. So there's only a 3-month interval between these two mammograms. And what you notice has developed is skin thickening diffusely. There's also increased parenchymal density on the mammogram. And in isolation, this is highly suspicious for an inflammatory breast cancer. That is breast cancer that spreads into the lymphatics of the dermis and often into the axillary lymphatics as well. It's highly aggressive, and then as the lymphatic system obstructs, you start to get this buildup of fluid, both in the breast and in the skin of the edema. This patient underwent a contrast-enhanced MRI. This is the MIP image from that MRI. And we see a very large breast mass. We see asymmetric enlargement and enhancement of this breast, and we also see enhancement in what were very large axillary nodes. This patient underwent a PET scan, and unfortunately we saw on the PET scan widespread axillary, mediastinal internal mammary, supraclavicular nodal metastases, as well as just widespread osseous metastatic disease throughout the axial and appendicular skeleton. Unfortunately, this is fairly typical for inflammatory breast cancers. This patient actually died 3 months after her diagnosis. That's how aggressive these cancers can be. This is another case. This was a 44-year-old, and this is a cool case because it shows a few tricks that nuclear medicine has to help answer questions that a breast surgeon might have, for example. So this FDG PET-CT was performed 5 years after she had had left breast treatment for invasive ductal carcinoma. And you can see the lumpectomy site on the left breast here. And you also see focal uptake in the right axilla in this level 1 axillary node. And so this became a bit of a diagnostic dilemma, and let me explain why. There's two potential explanations for what we're seeing here. The first is that this is a metastasis from a prior left-sided breast cancer that is now manifesting in the contralateral right axilla. The other option is that this is a nodal metastasis from a new but occult right-sided breast cancer that you cannot see. If this were evidence of an occult right-sided breast cancer, then the surgical team would consider a mastectomy potentially. If, however, this is related to the left-sided breast cancer, then they would simply do an axillary dissection, probably some surgery, as long as there's no evidence on the left. And so they reached out to us in nuclear medicine on what we can do, and we did say we can probably sort this out, and what we did was a sentinel lymph node injection and imaging. And so what we did is injected the left lumpectomy site with some technetium and sulfur colloid, and then we imaged over time. And we did in fact prove that this left-sided injection did end up tracking to the right side. This is a SPECT CT image that we obtained at about 4 hours. And you can see uptake in this right node. So this is presumed to be a nodal met from the left initial primary tumor that was already known. Kind of a cool case. This is another case that's important for breast interpretation on a PET scan. You notice that there are silicone implants here. You can't actually tell on CT per se that these are silicone, but they are. And if you note on the left, the capsule is showing some irregularity here. And when you see that on CT, it doesn't always confirm an implant rupture, but it certainly raises suspicion. And what you see here are that there are multiple lymph nodes that also have low level but abnormal uptake, and they're also a little bit large, especially this internal mammary node is too big. And so the question here, of course, is this evidence of breast cancer, or is this simply silicone from a ruptured implant that is traveling through the chest into the lymph nodes? How do we sort this out? Well, one thing you can do is ask your breast imagers to get a breast MRI, and they can do silicone selective sequences where the only thing that's bright on the MRI is silicone. And in this case, you do confirm. For example, on this image down here, you see, sorry, it keeps advancing again. You see that there is high signal in this node, so that clearly has silicone. You can also go on to ultrasound and you see this very characteristic dirty shadowing appearance. So both of these, MRI and ultrasound, both confirm silicone is in these lymph nodes. Therefore, these are likely not metastases, but the uptake we're seeing is simply inflammatory from silicone-laden nodes. This is a pretty classic case I want to go through. So again, we have a mammogram that was before on the left and later on the right. This was 6 months in between these two mammograms. On this initial mammogram, this mass here in the central breast was identified, and it was actually biopsied and came back as a fibroadenoma. We recommended a 6-month follow-up due to the potential that this could be a phylloides tumor. And in fact, at 6 months, you also now see a palpable marker. This is substantially increased in size. When you see this as a breast imager, you refer these types of cases to be removed. You want this mass to be removed, and it confirmed not only a phylloides tumor, but concern for a malignant phylloides tumor, which is a fairly rare entity. This is one of my favorite images because you can kind of get the whole diagnosis and spectrum of disease from this single image. So what you see in the right breast is this very hypermetabolic phylloides tumor that we know about. And then you see scattered lung metastases. And what you do not see are lymph node metastases, because phylloides tumors typically go directly from breast and then spread hematogenously, most classically to the lung. But you do not expect to see axillary metastases. So with the case of a potential malignant phylloides tumor, step 2 after diagnosis is not staging the axilla, but it is staging the lungs and the chest by getting a chest CT or an FDG PET CT. This is a case that, again, shows that not everything that lights up in the breast will be breast cancer. Even on a mammogram, similar story to what we've seen before, where you see this increased density in the breast. This was 1 year between mammograms. She went on to biopsy and then had a PET scan, and this is a diffuse large B-cell lymphoma, very large, occupying a lot of this right breast. On this MIP, you also see that there's some tonsillar uptake. You can also see diffuse renal uptake, so this is doing what lymphomas often can do, where you have this diffuse renal involvement, and then also a retroperitoneal lymph node. Another case here, and this shows that not all breast cancers are identified on an FDG PET. This was a copper 64 dotatate that was performed for treatment response for a pancreatic neuroendocrine tumor that had been resected. And you see it better on the fused axial PET-CT that there is somatostatin receptor uptake. There's binding and uptake on this dotatate scan in the breast. And so appropriately, this was sent for breast imaging evaluation and biopsy, and this was confirmed to be an invasive ductal carcinoma. So not everything that lights up on a dotatate or even a PSMA PET scan is prostate or neuroendocrine tumor. In fact, some subset of breast cancers will show uptake on both scans, meaning both dotatate or PSMA. They both can have uptake in breast cancer. There's some therapeutic implications to that, that those cancers that show uptake could potentially be treated with Lutathera and Pluvicto. Those trials are just getting underway now to see, can we actually treat breast cancers with these agents? So I want to focus the last 10 minutes on invasive lobular carcinoma. This is a very underappreciated, in my opinion, malignancy by radiologists, and we need to better understand lobular cancer, what's typical, what normal disease spread is. ILC is the second most common subtype. There's 44,000 cases in the US. If this were its own cancer, it would be the 5th most common cancer in females overall. And ILC, invasive lobular carcinoma, has many challenges. First, it often induces minimal anatomic change. So what I mean by that is it can completely be metastatic to lymph nodes, and the lymph nodes will look completely anatomically normal. It can be diffuse in the breast, and you won't see a mass on imaging, you won't feel a lump on physical exam. Not in every case, but it certainly can do this. And then ILC often metastasizes to sites that we frankly struggle with on imaging, and what I'm talking about are things like the bowel surface, the serosa of the GI tract, diffusely the stomach, CSF surfaces, peritoneal linings, things like that are common sites of spread of lobular. But things that all areas of the body that, for example, on a CT scan are really challenging. And ILC, like I've mentioned many times, many times it does. It certainly does in many cases, but it may not take up FDG, so you might not see it on an FDG PET scan. So I've kind of already gone through this, but the point of this is that because we can't see it well on imaging, we often detect ILC a little bit later. It can have more challenging for therapy because clinicians may not be entirely sure the extent or spread of the disease. And it certainly is very frustrating for patients. I can tell you that for sure. I've heard from many lobular cancer patients that are very frustrated that we can't see their disease better. So this is a case, and these two FDG PET scans were performed 2 years from each other. This scan on the left is the first one, and this lymph node uptake was identified, reported as potentially suspicious. It was biopsied. Here you see a biopsy needle through that lymph node. The biopsy came back as negative. Everyone said this is great, no cancer. She went back to surveillance. 2 years later, had a PET scan again. This time we're now seeing subtle but focal uptake in the subareolar breast. And again, we saw uptake. The subareolar breast, you see that has increased between 2 years. And then this lymph node still had uptake. Notice how the lymph node is not anatomically enlarged. This time, both sites were biopsied, both were lobular breast cancer. This just illustrates how elusive and sometimes slowly progressive lobular can be. In this case, I anticipate the lobular was here initially, and it just wasn't in the part of the node that was biopsied. This is another case of a very obvious lobular breast cancer in the right breast, diffuse. There's a mass, there's non-mass enhancement throughout that breast. On the MRI, there are also abnormal axillary nodes. She underwent both MRI of the pelvis and FDG PET-CT. And the interesting thing to me here is that on both cases, our radiology teams primarily said that these areas of abnormality, meaning this thickened and enhancing bladder, and this uptake at the ureterovesicular junction where the ureter is entering into the bladder, were most likely related to a primary urothelial carcinoma. However, if you understand the spread of invasive lobular cancer, you know that this is completely in the wheelhouse of where lobular cancers like to go. The linings of the ureter, the lining of the bladder, and upon biopsy, this came back as invasive lobular carcinoma. She also developed a new pleural effusion, and what that should tell you in a lobular cancer patient is that this is first most likely to be lobular breast cancer that has metastasized to the pleural surface. Again, going into FES PET-CT for the last 5 minutes here, I'll show several cases. In this case, this patient had a biopsy-proven right breast lobular cancer. On FDG PET-CT, these were performed within a week of each other. The FDG PET-CT really only showed uptake in a left axillary lymph node, which was related to COVID vaccination. However, the FES PET-CT showed extensive uptake in the right breast that was not seen on the FDG scan, and that is known lobular cancer. This is another case here where the FES very nicely shows a lobular breast cancer, and it also very nicely shows uptake in an anatomically normal left axillary lymph node that was biopsied and confirmed to be metastatic lobular breast cancer. In this case, this patient was being restaged for recurrence of ILC and first underwent an FDG scan, which did show evidence of metastasis in the breast, an axillary lymph node, and a mediastinal node. So this would be oligometastatic stage 4. But then she underwent FES, and look how many more sites you're seeing that we did not see on the FDG. And this confirmed widespread osseous metastases, over 100 lesions, and much more extensive lymph node involvement than was manifest on FDG. So what FDG is likely showing us are the sites of disease that are the most de-differentiated, and FES is showing us the sites of metastatic disease that will still be well differentiated because they still have the estrogen receptors that bind estradiol. This is a striking case where staging on FDG showed no disease identified. This bowel uptake is due to metformin, as we had seen on the prior lecture. And then a week later underwent an FES scan, and there was extensive axillary disease. The entire axilla and up into the supraclavicular space was involved with metastatic lobular cancer. And there were also 2 bone lesions, which I've shown here in the right scapula and the right iliac bone. So in this case, FES correctly staged the patient as stage 4. This is another case where FDG again did show a primary breast cancer. You see the biopsy clip here at the site of proven lobular cancer. You also see a biopsy clip here at sites we already knew were metastatic in the axilla, but there is no distant disease. And on FES, we are seeing distant disease. There is evidence of multiple supraclavicular nodes. Here's all the axilla. Here's a skin lesion. I told you breast cancer can frequently go to the skin. There's a skin metastasis. As we come around here, this was actually a pancreatic body metastasis. And then we have a bone metastasis. And here, I want to point out this is peritoneal metastases. See this linear uptake along the peritoneal surface in the pelvis. So very nicely seeing the peritoneal metastasis. And then probably what was my favorite finding on this, I mean, terrible for the patient, but a win from an imaging perspective that we are able to see this, is that you can see uptake along the coating of the cerebrospinal, the CSF, the coating of the cord. This is a German term often applied to this, Zuckerguss. And then you also see uptake in the neural frame and exiting nerve roots. So you see this nerve root and CSF surface, spinal cord surface, leptomeningeal coating of lobular breast cancer. So I don't want to give the impression that FES is perfect with lobular. It also can struggle, but in certain cases it really shines and can help reveal disease that we didn't see before. So with that, I will end, and I thank you for your time and for inviting me to speak.
We thank Professor Covington for his remarkable speech about PET-CT in breast cancer. And now I am pleased to invite Professor Morton for her speech about neuro-oncology. Professor Morton is double certified in nuclear medicine as well as in diagnostic radiology. She was the